Welcome to the module, the 5 A's Intervention for Tobacco Cessation, a Frontline Forces training presented by Superior Health Quality Alliance, or Superior Health. This learning module was developed for direct caregivers working in multiple healthcare settings who care for a variety of patients and who talk with patients about tobacco cessation. It is also relevant for family members caring for a loved one in the home. Direct caregivers play a very critical role in providing care to individuals in many settings of care. Why? Because direct caregivers spend a great deal of time with their patients, which helps them get to know and better understand the needs of these individuals. The purpose of this course is to further your learning and build on your current knowledge about how to talk with patients about tobacco cessation. What you know and how you use that information improves the quality and safety of the patients you care for. This learning module is part of a series of modules exploring tobacco cessation strategies to help patients, staff, and communities to reduce the use of tobacco. You are viewing the first module of the series, which provides a general overview about the 5 A's intervention for tobacco cessation. It is not necessary to complete the entire series of modules in one sitting. You can leave and return to any of the modules at any time. Once you have completed this learning module, you may test your knowledge and understanding of the material by completing the quiz. Upon completion of this module, the learner will be able to describe the 5 A's of tobacco cessation counseling and articulate questions to engage a patient in conversation about tobacco cessation. The 5 major components of tobacco dependence treatment are often referred to as the 5 A's intervention. Ask about tobacco use. Tobacco should be considered a vital sign. Advise to stop. Assess willingness to make an attempt. Assist in the stop attempt. And arrange for a follow-up visit. A physician does not need to deliver all of these elements on their own. One clinician, for example, a medical assistant, can ask about tobacco use status, and a prescribing clinician, perhaps a physician, dentist, nurse practitioner, or physician assistant, may deliver personal advice to quit, assess willingness to quit, and assist with medications, but then refer the patient to a tobacco intervention resource, for example, a tobacco quit line or a health educator that would deliver additional treatment to the patient. The United States Public Health Services Clinical Practice Guideline for Treating Tobacco Use and Dependence emphasize the importance of clearly identifying staff roles and including tobacco dependence treatment components in position descriptions. Having a dedicated tobacco dependence treatment quarter, ensuring that evidence-based treatment is provided in a timely way and clear communications with staff are maintained is important. Motivational interviewing techniques can be used along with the 5 A's to work with patients to achieve tobacco cessation. Motivational interviewing is an approach that attempts to move an individual away from a state of indecision or uncertainty and towards finding motivation to making positive decisions and accomplishing established goals. Let's go over the main components of motivational interviewing. The first is empathy. This is where you build an understanding of the patient's issues, struggles, and barriers of improvement. By doing this, the patient becomes open and freer since there is a lack of judgment and criticism. For example, use a statement such as, "Sounds like this is really challenging. No wonder you feel overwhelmed." The second is discrepancy. Have the patient point out the disparity between what they are doing and what their goals are. Do this by asking questions like, what is enjoyed about the behavior and what is not enjoyable? The third is to avoid arguing. See the situation from the patient's point of view. No one understands it better than the patient. Act as a support rather than a persuader. Next is to roll with resistance. Understand the patient point of view and avoid the desire to correct their behavior. And lastly is self-efficacy. Illustrate areas of strength and compile instances where the client was able to accomplish their goal. For example, it seems like you've been working hard to quit smoking. How have you been able to do that? Now let's walk through each of the 5 A's. I will also provide you with some example statements using motivational interviewing strategies to start the conversation with your patients. First, you will want to ask every patient about their tobacco use status at every visit and document the status. Using the 5 A's model, it is always important to ask patients permission to speak to them about smoking and tobacco use. This shows that you have respect for them and value their input. If the patient refuses to give permission or simply says, "No thanks," accept this, thank them for their time, and move on to another part of the visit. If they do grant permission, you can then proceed with questions. Ask patients about their current and past smoking patterns, and then go on to the next step, which is advise. Some examples of ways you can start the conversation are, is it okay if I ask you about your smoking status? Do you mind if we talk more about your smoking today? Or do you currently use any type of tobacco products? Step 2 is advise. Advise every patient about the benefits of quitting tobacco use with a message that is clear, strong, and individualized. Engaging the patient in conversation about their tobacco use can help create discrepancy. That is the difference between where they are now and where they can see themselves in the future, tobacco-free. Using the cons and pros approach, focus on the cons or the concerns that the patient has about their smoking. Most patients will have no problem identifying the pros of tobacco use. You want them to talk about the negative factors associated with their habit and to create discrepancy, which is another term for cognitive dissonance. Getting the patient to begin to see that their behavior change would be beneficial to them. Some examples of how you can incorporate this into the conversation are being clear. What are your concerns about smoking or tobacco use? What are your concerns about quitting? Making sure it's personalized. May I tell you what concerns I have about your smoking or tobacco use as it impacts your X condition? And make sure it's strong. Anything you can do to cut back can make a difference. Step 3 is to assess and determine a patient's readiness to change. Summarizing what you have discussed, use paraphrasing to remind the patient about the cons associated with tobacco use. Assessing the patient's readiness to change can at times be easy and other times not so much. Some of the techniques you can use are listed on this slide. It is okay to ask the patient something like, what are you willing to do today about your tobacco use? How different would your life be without tobacco use? What do you see as the cons and pros of tobacco use? What is your biggest fear about quitting? What is your biggest fear about not quitting? How confident are you that you can attempt to quit? Developing and agreeing on a plan will also help. Even if the plan does not include quitting completely, you and the patient may be able to develop plans to cut down on the amount or the frequency of their tobacco use. Remember, every step in the direction of change is positive. Assess patients' readiness by listening attentively and paraphrasing instead of resorting to challenging or arguing. You can say something like, I hear you saying this. Is that right? Don't be discouraged if there appears to be no movement. Roll with the resistance. Do not challenge or berate the patient for not selecting the plan that you believe is the best for their health. You can say something like, it sounds like you have some concerns about quitting. Can we discuss them? You need to understand at what stage a patient is to determine their readiness for change. So let's walk through all of these stages. First is pre-contemplation. In this stage, people do not intend to take action in the foreseeable future, defined as within the next 6 months. People are often unaware that their behavior is problematic or produces negative consequences. People in this stage often underestimate the pros of changing behavior and place too much emphasis on the cons of changing behavior. The next stage is contemplation. In this stage, people are intending to start healthy behavior in the foreseeable future, again defined as within the next 6 months. People recognize that their behavior may be problematic, and a more thoughtful and practical consideration of the pros and cons of changing the behavior takes place, with equal emphasis placed on both. Even with this recognition, people may still feel ambivalent toward changing their behavior. The next stage is preparation or determination. In this stage, people are ready to take action within the next 30 days. People start to take small steps towards the behavior change, and they believe changing their behavior can lead to a healthier life. The next stage is action. In this stage, people have recently changed their behavior, defined as within the last 6 months, and intend to keep moving forward with that behavior change. People may exhibit this by modifying their problem behavior or acquiring new healthy behaviors. The next stage is maintenance. In this stage, people have sustained their behavior change for a while, as in more than 6 months, and intend to maintain the behavior change going forward. People in this stage work to prevent relapse to earlier stages. The next stage is termination. In this stage, people have no desire to return to their unhealthy behaviors and are sure they will not relapse. Since this is rarely reached and people tend to stay in the maintenance stage, the stage is often not considered in health promotion programs. And lastly, there is relapse, a return to the unhealthy behavior after any period of success. This is especially true with tobacco cessation. There are multiple psychosocial variables that contribute to relapse in tobacco use. Some of these include social influences, such as friends, family, and acquaintances, strong conditioned responses to consume tobacco, such as eating, drinking, and socializing, the lack of healthy alternatives to occupy time and focus, such as exercise or hobbies, and also the desire for the physiological effects of tobacco, those cravings, which may contribute to relapse. This slide shows the stages of change in a visual way. It shows that a person enters the stages of change at pre-contemplation, but that they can exit and re-enter at any stage. Step 4 is to assist patients who are ready or considering change to create a quit plan. Quit plans can include pharmacological intervention, setting a quit date, counseling, and social support. At this point, if the patient is open to quitting or thinking about it, the availability of resources can assist them in moving forward with their plan. Remember, if the patient is not willing to make any changes, you can ask permission to provide them with materials and thank them for their honesty. Have tobacco resources readily available to present to the patient. Keep these resources in places where all staff can access them. Here are some examples of encouraging conversation. Please describe to me the last time you tried to quit. What kinds of support do you feel would help you quit? If you're not ready today, can I give you some information? Is it okay if we have a follow-up conversation about this another time? The last step of the 5 A's is to arrange. Connect patients who are ready to quit to resources and schedule follow-up. Follow-up is most helpful to do within the first weeks of a quit date and can either be in person or via telephone. During this call, encourage the individual to remain in quit status. Discuss any obstacles and how to overcome them. Congratulate success for those who have been able to quit or cut down on their smoking. For those who continue to use tobacco, repeated use of the 5 A's is important for supporting motivational changes over time to move toward action for quitting tobacco. It's important to develop a follow-up protocol to use with patients who have agreed to stop using tobacco. Who, when, how, what information will be covered. The majority of relapse occurs in the first 2 weeks after quitting. Some tips for encouraging conversation are, can we set a quit date? Can I help you find some resources to support you in quitting your smoking or tobacco use? Can we talk about nicotine replacement therapy or medications that can help you quit? Is there a quitting method you would prefer? Let's summarize what we've agreed upon today. Congratulations! You have successfully completed this module. It is now time to test your knowledge by taking the quiz. Click on the link for the 5 A's Intervention for Tobacco Cessation quiz on the Frontline Forces webpage or in the YouTube description below.